Hello, and thank you for joining us for today's webinar. Today's webinar, Management Options for Pituitary Tumors, is presented by Norberto Andaluz. Dr. Andaluz is a neurosurgeon with the Mayfield Clinic and University of Cincinnati Brain Tumor Center. He is also Associate Professor of Neurosurgery at the University of Cincinnati, Surgical Director of the Neuroscience Intensive Care Unit, and Director of Neurotrauma at the University of Cincinnati Neuroscience Institute. He specializes in the treatment of all disorders and diseases of the brain and spine, but in particular traumatic brain injury, aneurysms, anteriovenous malformations, intracerebral hemorrhage, stroke, carotid artery disease, moya-moya disease, and brain tumors, with special training in skull-based tumors like pituitary adenomas. Dr. Andaluz received his medical degree from Universidad Nacional de Rosario in Argentina. He completed his residency in neurosurgery at Instituto de Neurología y Neuros maybe you can say that better than I can, also in Argentina, and earned a fellowship in cerebrovascular surgery from the University of Cincinnati. Professional memberships include the American Heart Association, Congress of Neurological Surgeons, National Neurotrauma Society, Neurocritical Care Society, and North American Skull-Based Society. In addition to that, he is also a member of the Pituitary Network Association. We are going to start the presentation after we switch presenters. We offer these webinars to help educate patients, their families, and their healthcare providers. The Pituitary Network Association is a nonprofit organization that relies on the support of our members and donors. During the webinar, you will have the opportunity to type in questions at any time, but please note that we will save them all till the end of the presentation, and we will go through as many of them as we can. If there are more questions than we have time for, we will answer what we can by email. I'm now going to turn it over to Dr. Andaluz. There will be a brief delay as we change presenters. Okay, Dr. Andaluz, you should see something to accept on your end. Perfect, I see your screen. All right, I can hear you. It's all yours.
Okay, good afternoon, and thank you, Tammy. Thank you to the Pituitary Network Association for the opportunity to be presenting this webinar. I also want to thank Tonya Hines, our medical communications director at the Mayfield Clinic. As Tammy said, I'm a neurosurgeon in Cincinnati. I work at the UC, University of Cincinnati Brain Tumor Center and the Mayfield Clinic, and I'm here to talk about management options for pituitary tumors. So thank you again for joining. I will go as quickly as possible through my slides so I can give you the opportunity to ask as many questions as you want. So what causes pituitary tumors? Well, we really don't know what causes pituitary tumors. They are not associated with any known environmental factors. They're very frequent. There are a number of studies that show in autopsy series that as many as 25 people may have some pituitary adenoma. Of course, the big majority are asymptomatic, which makes it very difficult to understand what the natural history is. However, from all these pituitary tumors, there's a certain subset that produce hormones, and those become very evident by some of the symptoms they create. 25% of people with a syndrome called multiple endocrine neoplasms, or MEN1, there's 3 subdivisions of this, will develop a pituitary adenoma. Again, going back to some of the epidemiology, there's 10% in autopsy studies, but when we look at some of the modern studies into MRI series, people that get MRIs for different reasons, up to 1 out of 3 have some kind of pituitary abnormality when you look at different studies. Which makes it very difficult for us to understand what the natural history is. Only we know about the people who will develop a symptom. We will not know what happens with those who are asymptomatic, and that's what the challenge is. So what we do know is that non-functioning adenomas are 4 times more likely to grow, and that's something that we always keep an eye on because of the consequences that it may carry, and you will see later on. When you look at some of the studies, mostly from Europe, you see that these tumors are not infrequent, and we're talking about symptomatic tumors. And you will see that between the ones which produce hormones, the prolactinomas, or the ones that produce the prolactin, are the more frequent ones, and the non-functioning are the other big bucket of patients with this. Talking about genetic factors, I touched briefly on the MEN1, the multiple endocrine neoplasia or neoplasms that affect multiple endocrine organs, the parathyroid, the pancreas, and the pituitary. These other markers that I'm listing here, they're just found and they're used in research studies. There's no clinical use to this. Really, the only value for genetic studies or identification of genetic factors is people with multiple endocrine neoplasms. So what is typical of pituitary tumors? Well, they grow slowly as a rule. They grow very slowly. They vary in size and direction of the spread. As you see on this insert here, these tumors are contained into a very specific part of the skull called the sella turcica, which is a bony structure mostly, surrounded by the carotid arteries, some of the nerves that help us move the eyes, and more particularly the optic nerves, which are one of the things that we're going to be worried about when these tumors spread. They may spread, as you can see here, in these different directions towards the... I had a little technical problem. This mouse. There it is. Sorry, thank you, Tonya. And they may extend superiorly towards the optic nerves, laterally to the carotids, or maybe even beyond the cavernous sinuses, and that's where we're going to be paying attention to see where our strategies will be to try to overcome some of the symptoms from compression. They may present sometimes with seizures if they grow too far to the side and affect the temporal lobe, or they may cause what we call hydrocephalus by blockage of the flow of cerebrospinal fluid. I like this chart because it shows you, if you look at it, I'm not going to use my pointer this time because I already caused a problem. It shows how the compression of the tumor over the optic pathway, what we call the chiasm. Chiasm in Greek means is a crossing point, where the optic nerves cross is just immediately above the area where the pituitary gland is. And if the tumor grows to the top, keep in mind that below the pituitary there's bone, so the only place where it can go up, where it can go is up. It may compress the optic nerves. So the areas that get most affected are the ones that are where these nerves cross. And if you pay attention to the lines there, you will see that the more central views are the ones that are related to what you can see with the side of your eye. So we call those the temporal sides versus the nasal fields that you have, the more central ones. So the ones that get affected earlier with pituitary tumors are the temporal fields, and we call that bitemporal hemianopsia. And you can see some of the maps there with the different ways of affection, but initially, as a rule, the ones that will get affected the first will be the temporal fields. Going back to the tumor types, as I said, the non-functional are a significant amount of the tumor population. They cause symptoms mainly by compression, by extension, and then the functioning ones, the prolactin, are the more frequent one. They can give pretty dramatic symptoms, and we call these syndromes. So going to the most frequent one, the prolactinoma, they're very frequent. They're about almost 1 out of 3 pituitary tumors. The good thing is that this could be treated or controlled with medication. There's a really old medication called bromocriptine that is very effective. There's one a little bit newer, there's cabergoline, that's a little bit more effective, it's better tolerated, and between the two, pretty much 90% of the patients can have a reduction of the tumor. The reductions are pretty dramatic. You can see, I'll show you an MRI in a few minutes showing how the effects of the medication. This is only 6 weeks after the treatment. You can see on the left side of your screen a significant tumor extending into the optic nerves, extending into the brain. And you can see only after 6 weeks of bromocriptine for this patient was, or cabergoline, the tumor decreased in size dramatically. It shrunk completely. You can even see the optic nerves now and the optic chiasm free of compression on the right side. So as you can see, this is a very effective treatment, and we always choose this unless in some specific situations, which are this. What happens? You have to do surgery. When do you do surgery? Well, surgical treatment is necessary when the drug therapy is unsuccessful. As you saw in the previous slide, there's a certain amount of patients that are not responding to or not responsive to the medication. So for those patients, surgery is an option. When the vision is significantly compromised, you may have huge prolactinomas that are making the patient blind, and for those patients you may not have the time to afford the treatment with the prolactin and with the prolactin antagonist, and you need surgery. Women with macroadenomas attempting to get pregnant, and I'll touch on this in a little bit. What's the efficacy of surgery? Overall, when you look at all the patients with prolactinoma, all comers, the efficacy is about 50%, 53%, ranging up to 70, 80. The overall recurrence rate, the chances of the tumor coming back, is about 15, 20%. And why is such a big deal with the prolactinomas and the pregnancy? Well, as you know, during pregnancy, there's a dramatic change in the hormonal environment of the woman. And as part of that, there's high demands for the pituitary gland, which enlarges dramatically. As a matter of fact, sometimes it's a confusion because of the size of the pituitary gland and how much it enlarges, that it may confuse some people thinking that they may have an adenoma because of the size of the pituitary gland. So imagine if you have a pituitary adenoma and your pituitary gland is going to get larger, it's going to be a big deal eventually. So what is the risk of a tumor enlarging? If you have a microadenoma, fortunately, it's very small, less than 3%. Now, what happens if you have a macroadenoma? Well, 1 in 4 will have a significant tumor enlargement. And that is a problem because it may cause compression of the optic nerves and may cause you blindness, can cause also by compression may affect the function of the pituitary gland, and you may have some hormonal derangement. So what do you do? I mean, can you use the cabergoline in these patients? Yes, you could, and we've had patients that have used it. In general, there's always the argument of trying to eliminate any kind of toxic to the fetus and the babies. So there's concerns with the malformations and so forth, particularly with the bromocriptine, which in the past for Parkinson's disease, that's an old Parkinson's disease drug, used to cause some cardiac problems, but it's not seen on the babies. Nevertheless, there's always a concern. So they try to eliminate the use of any medication. Therefore, patients with a macroadenoma, current endocrine guidelines recommend considering surgery prior for the patient getting pregnant. Let's say somebody discovers they have a pituitary macroadenoma and surgery is needed. Ideally, you want to do this in the second trimester. It's just better tolerated. There's less risk to the fetus and to the mother. What happens with patients with pituitary tumors, and which are prolactinomas and breastfeeding? Because as you know, prolactin is the breastfeeding hormone. Well, it is an option for patients with micro and macroadenomas that have remained stable. We're usually very liberal, and we allow them to breastfeed, even though we know that it may enlarge the pituitary gland. So moving on to another of the dramatic symptoms, we're talking about Cushing's disease. And I like these slides because it really summarizes some of the features of Cushing's disease. Is people that have this very discordant fatty deposits in the body. You have these buffalo humps. They have some growth of hair in abnormal areas. They have this very prominent abdomen, like a beer belly almost, and they have very thin extremities. These are all effects of the increase of cortisol in your body, and that's, if it's a cosmetic problem, it's not so much of a problem as all the cardiovascular risk. Now, the only cause is pituitary tumors, the only cause of Cushing's disease. By the way, Cushing was a neurosurgeon who first described this syndrome. No. Actually, there's a number of other causes of Cushing's disease or hypercortisolism which could be related to adrenal tumors because that's the end organ, or ectopic secretion of ACTH. There are some tumors, particularly some forms of lung cancer, that can secrete the hormone that stimulate your adrenal glands. So there's a very sophisticated way of trying to figure where this is coming from, all the way from examining your abdomen, getting venous blood from your brain, from what we call the cavernous sinuses, to try to determine where the ACTH comes from. But what do we need to know that is practical? Untreated Cushing's disease is lethal. It kills people. So we have to be very aggressive with this, and the treatment of choice is to remove the tumor. Now, one of the difficulties with Cushing adenomas is that they tend to be microadenomas, very, very small tumors. So the success of surgery sometimes could be affected by this because they may be hard to find, hard to discover. And that's where sometimes comes the repeat surgeries. And we tend to do repeat surgeries if the cortisol levels are not reduced right away, because we know that it's easier to reoperate right after surgery than going back and waiting for all the scar to form, because it's harder to operate. But we have had extreme cases where we have had to take parts of the pituitary gland when we have localized it to be sure that we have reduced the tumor. And treatments can get, if the medication does not work, because there's really not a 100% effective medication, it can go as aggressive as removing your adrenal glands. Radiation therapy has a role, but it's not always immediate, but it may help, for some patients that have residual tumors, or particularly with those with invasive large tumors that cannot be completely resected. Acromegaly, another dramatic syndrome that also has increased mortality. The growth hormone tumors, the hypersecretion of growth hormones. You see that people change. These are the patients who over a short period of time change their shoe sizes, cannot wear their wedding rings anymore. They have these enlarged soft tissues. Their faces change, their shoe sizes change. They have all these other problems like sleep apnea. They become diabetic. They have joint pain. Their voice changes. They have very dramatic physiognomic changes, and these are related to hypersecretion of growth hormone. Again, these are the criteria for diagnosis. You can read them. They tend to present more, contrary to the Cushing's, which tend to present more like microadenomas. These tend to present more like macroadenomas. Here's another picture of somebody who's been treated, actually. And you can see the reversal of some of the features after they have been, quote unquote, cured from acromegaly. The treatment, again, treatment of choice is surgery. There are some drugs that can help, like the octreotide and the pegvisomant, that are helpful. They're not first line. We use them only as an adjunct, or unless patient cannot have surgery for a certain reason. But the cure really reverses some of the risks associated with the mortality, which is usually cardiovascular mortality. Like I said before, the treatment of choice is surgery. The cure rates are high and early, but they tend to recur, particularly the big adenomas. Many times we present with invasive adenomas that take on structures that cannot be removed, let's say when they invade your cavernous sinus or your carotid arteries, and there's still residual adenoma for those. Those are the ones that will require the radiation therapy. Those are the ones that will require the drug therapy. TSH adenomas. I did not even mention this at the beginning because they are rare. I have seen a handful in my career. And these are the ones that also could present with serious effects. Usually I've seen them present with cardiac arrhythmias because of the increase in the thyroid hormones. You get arrhythmias where your heart beats very fast, and during the workup they discover that they have a TSH adenoma. Treatment, again, for all endocrine producing tumors is treatment of choice is surgery. There are ways to mitigate some of the effects, but again, radiation therapy also may have a role in this. What about the other big category, the non-functioning adenomas? Well, there's two types of non-functioning, if you will. One is the one that is the support cells of the pituitary gland, and the other one is incomplete change of these sex hormones, the gonadotropes, the ovarian, the follicle-stimulating hormone, and the luteinizing hormone. they produce these fragments of these inactive hormones, and they tend to present more with either hormonal deficiencies for compression of the normal pituitary gland, or because they just become very large because they're silent. So they present with visual disturbances or with some of symptoms of hypopituitarism. The treatment depends on mostly the tumor size, really. If the tumor is very big and there's visual compromise, they're going to go to surgery. If they're small, which many of these are incidental findings, they're just being followed with imaging, and they don't really require any more treatment than surveillance. Looking at things the other way around, we looked at the tumors that produce hormones. What about when the tumors don't produce hormones and affect your pituitary gland? Well, is this possible? Of course it is. The most common clinical deficit is with the sex hormones, the gonadotropes. So this is the women that cannot get their periods, or men that have some sexual dysfunction. They have higher chances of having an abnormality in the lab values than clinically, if it makes sense to follow this slide. And this is the ones that are most frequently affected, the growth hormone, that when you're a grown up, you don't really need much of a growth hormone, so you don't notice that. Pituitary incidentaloma. This is something so frequent that the American Endocrine Society posted a series of recommendations. And why is it called incidentaloma? Well, these are incidental findings. And you discover this because a patient maybe has multiple sclerosis or had a stroke and had an MRI, and they discover that they have a pituitary finding. They're extremely common. Up to 35% of people, depending on the MRI series, may have an abnormality on the pituitary. Is it always an adenoma? No, it's not always an adenoma. More chances that it is, but they're really incidental findings, and we call them incidentalomas. Obviously, if they will have any, they will be worked up, and if they're big, they're more likely to grow over time. So you want to keep an eye on those. And if they have any hormonal abnormality, well, they stop being an incidentaloma, and they may become either a functioning adenoma or something that will require further workup. So what do you do with incidentaloma? This is an example. You can see the arrow showing their finding on the pituitary gland, which is a microadenoma because it's less than 10 millimeters. You want to do some endocrine workup. Essentially, prolactin is what you want to know, the prolactin status the most, because those are the most frequent tumors. If the size is small, some people will debate that there may be no need for any further imaging. If the size is a little bit more than 5 millimeters, maybe you get an MRI every year for at least a couple of years to document stability. If these tumors are stable, there's really no indication for continuous follow-up, even though we do know of patients that are being followed up in the long term. What happens with a macroadenoma? Well, those deserve more attention. They have to complete an endocrine workup, make sure that they have good endocrine function. They need to have a formal visual field exam. If they do not have any symptoms, they will be closely followed up. You want to have visual field testing. You want to repeat an MRI at 6 and 12 months, and then yearly if you're concerned. If your non-functioning adenoma has some visual field compromise, the treatment of choice is surgery. Those patients need to be operated on because of a risk of continuous enlargement, or because of the risk of what we call pituitary apoplexy. You're going to see a slide on that. And you can see on this MRI the compromise on the optic chiasm, the relationship with the carotid artery. So how do we treat this? Well, we like to see this as what we call a team approach. And this is not a one-man show. This requires the involvement of, obviously, the primary care physician, the involvement of the endocrinologist, which is a key element, the involvement of an ophthalmologist or an optometrist, obviously the neurosurgeon and ENT surgeon, and the radiation oncologist that will also be part of this treatment team. So what are the goals of treatment? Well, the goals of treatment are to reverse your endocrine symptoms, to restore your pituitary function, to remove the tumor mass and to restore the neurologic function is necessary. So when do you operate? For microadenomas, usually for functioning tumors, if they're not controlled by the medication, if they are recurrent, or if they're secretory, which is the medication tumors that probably will not be treated with medication. Macroadenomas, same as when you have a microadenoma, but also for the mass effect symptoms, usually visual symptoms, or if they are in contact with the chiasm with significant distortion, or else if they're noticed to be enlarging on your serial follow-up MRIs that you're doing. This is another indication for apoplexy, for surgery, and this is about probably the only really true emergency in pituitary surgery, called pituitary apoplexy, which is a sudden onset bleeding into the pituitary. It's almost like a hemorrhagic stroke of your pituitary gland. Your pituitary has enlarged so much that there's not enough blood supply, and they may run into this situation called apoplexy. And it presents like many other bleedings in the brain, similar symptoms that you can get sometimes when you have a ruptured aneurysm, which is a very intense headache. You may have some double vision. You may have a sudden loss of your change in your pituitary function, people who become hypotensive, unstable with the blood pressure, hemodynamically unstable. They really require an emergent operation. The chances of recovering vision are inversely proportional to the time it takes for this to be treated, and sadly, we all have seen every once in a while patients become blind because of this. There is an increased risk of this happening during pregnancy. As I told you, the pituitary gland enlarges during pregnancy, and the symptoms are very dramatic. And sadly, many of these patients are unaware of having a pituitary adenoma. So how do you choose your surgical approach? There's several ways of treating pituitary tumors. I mean, the most common is through the nose, as many of you know. Could be done with the endoscope or could be done with microscope, but it also you need to consider where this tumor is going. And also that will define your goals for the treatment, and also some strategies. Some patients may require more than one operation, and some patients may not be good candidates for, let's say, a transsphenoidal operation. So if they extend superiorly into the third ventricle, that may be more of an indication of doing a transcranial approach. If they go inferiorly through the sinus, that may be a good candidate for a transsphenoidal approach. And patients that have all this extension lateral into all these critical structures like the carotid and the cranial nerves may require some combination of perhaps surgery and radiosurgery, or a combination of maybe two different approaches. So what is the goal of the surgery? The goal is to remove as much tumor as possible. Through the craniotomy, there's multiple variants. I'm going to show you some of the more modern examples. This is a little bit of an old way of doing it that you see on the left side. And then this, the transsphenoidal, that has become the workhorse of surgical treatment. Again, the one way that you see about doing it on the right side is the older way, where we used to open the mouth and go through the nose, degloving the face essentially and going through the nose to remove the tumor. These are some of the stages where you put a speculum called the Cushings speculum, and you access through the airway, through the nasal cavity, the base of the skull, at the floor of the sella, which is the pituitary gland region, and you remove the tumor from within. For the microscopic approach, this is the one that has been used most in the last few decades. For us surgeons, we have the advantage of the familiarity, and you can see 3D. The disadvantage is that you have sometimes a long reach, the visualization is limited. One of the other advantages is that if you don't have a good ENT partner, then you're pretty much on your own, so you have to do this by yourself. If you have the luxury that I have of working with one of the best rhinologists in the country, you will like working with endoscopes. The advantage is that you can have a much better view. You can see on some of the corners that you cannot see with a microscope, and it's a much more functional operation. you want to have your nose probably operated on by an ENT specialist rather than a neurosurgeon. We always joke about this, but there's some disadvantages. There's no depth perception. There's a 2D view, although there's now 3D endoscopes coming, but they're still in the very early era of that. So what are the contraindications? Can anybody have an endoscopic or transsphenoidal approach? No. If you have sinusitis, you might as well just cure your sinusitis before you get an infection in your brain. If you have your carotid arteries that are somehow coming too close to each other, we call those kissing carotids. That's a contraindication because they're going to be on your way. The other are relative contraindications, which are related more to the medical stability of the patient that can be easily corrected before surgery. This is one of the earlier endoscopes that we have. We have 0 degrees, 30 degrees, 45 degrees, and up to 70-degree views of endoscopes. These are some of the key anatomic relationships that we care when we do this operation. You can see on the left the sphenoid sinus, which is the cavity that the ENT open for us so we can access the pituitary. You see there in green. On the right side, you have a sketch of a patient with a pituitary tumor, and you can see from that view how it makes sense to go through your nostril. You have a straight shot, essentially, to the base of your cella, so you can access the pituitary gland. Another thing that I want to bring your attention to on the left side, the way that we do this with the endoscope nowadays, on yellow you see some of the little filaments that are related to the olfactory nerve, so you can see how the olfaction should not be really affected in the long term after patients recover from this. This is how the procedure goes about removing the tumor through the sphenoid sinus, and these are some of the instruments that we use, some different pituitary rongeurs and different specialized instruments. And that's part where you decompress the optic nerve that occurs indirectly most of the time when you remove your tumor. Can you do anything more than just taking pituitary tumors through the nose? Of course, nowadays we have acquired a technology and some of the instrumentation to go beyond the cella, beyond the pituitary gland area, where we can operate some of the tumors that extend beyond the area of the pituitary, and we call this expanded or extended transsphenoidal approaches. We have become more aggressive about doing this, and because there's less of the complications that are associated with a craniotomy. To do this, we use what we call image guidance, which, to make sense for everybody, is more like pretty much like a GPS. It really is very important for us for cases of distorted anatomy. How do you close this? On the left side, you see what is left after you have removed the tumor. We tend to pack this cavity so there's no herniation of the optic nerves into the, so they don't fall down into the area of the pituitary. And we cover this with a bone. We create something called a gasket seal. This is, you can see very nicely how it's sealed, and we sometimes use some of the patient's own mucosa or some of the biologic glues to help us close more effectively. So what are the outcomes of this? We have some reports comparing endoscopic versus macroscopic. This is all to be taken with a grain of salt. There's different ways of doing and reporting this, and this is something that in medicine in general, particularly when there are some procedures involved, there's a lot of variability. In this particular study, they reported that there was greater chances of removing more tumor with the endoscopic technique and less nasal complications. There was really no difference in CSF leakage, which is one of the complications, diabetes insipidus, which is some of the effects that you can have, hormonal effects, meningitis, and bleeding through the nose. This is another study that reported that there was less time needed to do these operations, and there was less discomfort from the approach from nasal symptoms, although for what matters, which is how much tumor you take, how much the incidence of CSF leak, or how much the chances on visual outcomes differ, there was no significant difference. What are the cost of treatments? This is from 2014. About 5,000 operations are reported in the U.S. annually. This costs $100 million, just the surgical costs. In this study, they determined that endoscopic surgery was a little bit cheaper when compared with microscopic surgery. And this only, like I said, accounts for the cost associated with the surgery and not the postoperative complications or the follow-up that is necessary. How pervasive is the use of endoscopy? It's coming up. It's more popular with the dual training that some of us are getting. The endoscopic approach has increased tenfold over the last decade. I actually learned how to do this microscopically, the same way as you saw sublabial. And then I was lucky to leave all this transformation where I became completely an endoscopic convert. Regionally, in the 2010s, early 2010, so I think that this has changed a little bit. Still, there was more of the microscopic technique used versus the endoscopic, and that was seen more in the southern and western region of the U.S. What are the results by tumor type? Prolactinomas. Well, again, it depends on the tumor size, tumor invasion. If they're a microprolactinoma, I have very good chances of cure with surgery, 85%. And you can normalize your prolactin with surgery only in a little bit over of 53% of patients. The recurrences vary. If it's an invasive prolactinoma, maybe 1 in 5 will recur. If it's a microprolactinoma, your chances of recurrence are very low. For growth hormone, initially 80 to 90% cure rate, but they tend to recur, especially if they're macroadenomas, like we said before. For the Cushing adenomas, would like to see better rates of success. Overall success rate 70%, chances of recurrence about 50-50. For the non-functioning, actually these patients tend to do better because they don't produce hormones. So you can have gross total resection in about 60%. The visual fields improve. In the big majority, in our own series, we have a 94% visual improvements. And the pituitary hypofunction may even, in some patients, the pituitary function may improve. What happens with postoperative hormonal deficits since we're doing surgery in the pituitary? Well, about anywhere between about 7 to 20% of patients will have a new postoperative deficit following the operation. And you see more of that in the Cushing's adenoma, and if you keep in mind that we tend to be particularly aggressive about Cushing's disease, you will see that we may be taking more pituitary gland in an effort to remove the Cushing adenoma. The risk of this varies depending on the type of tumor. Some tumors are very rubbery, so they're hard to take. Some are much softer. And it really varies on the type of tumor. Diabetes insipidus is very frequent. About 10-20% of patients will have some touch of diabetes insipidus in the first 24-48 hours after surgery. Permanently, the rate is very low. Olfactory outcomes. When you use the endoscopic technique, really the chances of having significant problems are very close to none. We see some dysfunction during the first 3 months, which we attribute to all the trauma related with the approach. But in our own patients, we have actually had some patients improve their smell because they had some sort of septum problems, deviated septum or chronic sinusitis, so they got the additional benefit of the cleanup by my ENT, Dr. Zimmer. Well, these are the approaches that we use sometimes when we don't have good candidates for an endoscopic transsphenoidal, which is usually our choice. So we resort on the transcranial approaches, and nowadays we're become very fond of the minimally invasive techniques, where we call keyholes, which are strategically placed openings in the head. They are small enough to give you the amount of exposure that you need to remove your tumor. Usually we do these operations with the objective to decompress the optic nerve or relieve some things like hydrocephalus or some irritation on the temporal lobe, let's say on somebody that may have seizures. So these are the keyholes that we use. They are all surrounding the eye, the orbit, the eye cavity. This is the supraorbital approach. We tend to make more incisions on the eyebrow. Sometimes we do it behind the scalp. This is one of our patients that had an eyebrow incision. You can see how nicely it heals 10 days afterwards. This is another technique that we described here in Cincinnati 8 years ago, the transorbital eyelid incision. We worked with a cosmetic oculoplastic surgeon, and we found a way of making an incision on the eyelid that allowed us to have a good exposure of the area where the pituitary is and other pathology. This is one of our patients, and you can see that the results are very good. You can barely tell where she had an incision on her eyelid. What are the complications with this? Well, they're similar as the complications with transsphenoidal surgery. CSF leak also can occur. You can have meningitis. You can have injuries to the hypothalamus. Probably chances are higher because you have been operating on a tumor that is large, and worsening vision or double vision is also a possibility. The role of radiation therapy. So why do we use radiation therapy? The goal is to reduce or control the tumor size. This is not a first line of treatment. We hardly ever treat with radiation a tumor from the get-go. This is usually an adjunct treatment. We use conventional radiation therapy and fractions, or what we call radiosurgery. These are the three modern ways of delivering radiation: radiosurgery, and CyberKnife, which are X-ray linear accelerator, and the gamma knife, which is the one that we have been using lately. So when is it used? Well, as I said, it's only after, or as a rule, after surgical and medical options have been exhausted. What is stereotactic radiation? And we use it, stereotactic is the same concept of using the GPS. It's a targeted dose of high dose of radiation, but there's only a specific target where you can use it. You can use it only on tumors that are no bigger than 3 centimeters in diameter, that's a little bit over an inch, and that are not too close to the optic nerves. We know that a safe distance to the optic nerve for delivery radiation is 3 to 5 millimeters. Fractionated is when you give a dose of radiation in small fractions to reduce the toxicity from the radiation to the optic nerves and the brain. For example, in this scheme, you see the pituitary gland and the optic chiasm, and you see the safe zone there in the stalk between the pituitary and the optic chiasm. This is a good case for radiosurgery because you can treat this patient effectively without with limited toxicity to the optic apparatus. This other one on the left, as you can see, is so big that it's pushing on the optic nerve. This is not a good candidate for gamma knife, so this patient will be more of a candidate for fractionated surgery. This is what it looks like on the radiation therapist, or one of my neurosurgeon colleagues helps with the planning, Dr. Warnick, who is the director of our brain tumor center. And these are the ways, these lines are showing you how the decay of the radiation goes in relation to the tumor. In the center is the tumor, of course, and the one thing that you see in green there is the brainstem. This is a graph of how the dose goes through those areas, and this is another example where you see some targeted radiosurgery to tumor infiltrating the cavernous sinus on that area. So what are the results? You can control the tumors by tumor control. We call it different than surgery. We as surgeons like to take the tumor out. For them, is for the radiation therapists to keep the tumor from growing. So that's why they use tumor control. And they can get very good rates, 90 to 100%. Tumor shrinkage is seen in 20-25% of the patients. Some patients do have an endocrine improvement, but this is temporary because in the long term it will also affect the pituitary gland and your pituitary function will get worse. In the long term, as I said here on this slide, 80% of the patients will have a hypopituitarism. All the pituitary hormones will be affected at 10 years. That's 80%, so that's not a neglectable rate of patients. Vision loss is a possible complication because of the radiation. As many of you may know, because of the use of radiation, that damages the DNA and then may cause secondary tumors. It's very rarely seen, but it's been reported, and what we call radiation necrosis. Stroke is a possibility, but really not very frequent. And with this, I finish my presentation. I want to remark that this is a team effort that involves many people, and of those I want to recognize Lee Zimmer, which is my ENT partner. I wish that he was here to share some of our experience with you. I really must say that this is not a one-man show, and all these people that you see here listed are equally as important as I am for treatment of these patients. Thank you very much for your attention.
Thank you, Dr. Andaluz. That was excellent. We do have several questions. First question is, in Cushing's disease, what is the incidence of a patient having an ACTH-producing tumor from another source, such as adrenal or ectopic, in addition to an ACTH-dependent pituitary tumor?
It is rare to see both at the same time, and I have a very elaborate slide where you can sort out with certain degree of certainty where this ACTH is coming from, and really the best way that we have is just to do what we call the cavernous sinus sampling, which is an evaluation of the venous drainage around the pituitary gland. So this is an interventional procedure done by a neuroradiologist generally, where they stimulate the pituitary with CRH, the corticotrophin stimulating hormone, and they can measure a few minutes after you inject this hormone, and you can see if there's a peak, a spike on the secretion of the hormone, and then that will orient you a little bit better.
Okay, thank you. Following an adrenalectomy for pituitary tumor and Cushing's disease, is it common to need a transsphenoidal surgery many years down the road due to mass effect from continued growth? And then Nelson's and in parentheses.
Yes, you can have actually there could be an enlargement of the pituitary gland if there's no cortisol as a feedback mechanism, because you will have an increased hormones act by feedback mechanism. So it's hard to explain in a simple way, but if there's no feedback from cortisol to the brain, to the hypothalamus, there will be a stimulation of the ACTH, and that may cause your pituitary gland to grow. So those patients, when they have been adrenalectomized, they will need some steroid treatment.
Okay.
So they're very difficult to manage patients.
Sounds like it. Can you speak at all to fertility options in the event of panhypopituitarism?
Well, we will have to bring a fertility specialist, but yes, we do see patients of ours that have gone through different fertility treatments, and nowadays with the ovarian stimulation and the in vitro fertilization techniques, some people have gone through options of rescuing eggs, or so there's a lot of options, and they can be supported throughout the pregnancy by the endocrinologist.
Okay. I have a non-functioning macroadenoma that I have followed for 12 years. Recently, I have had slightly elevated levels of prolactin concurrent with a very slight growth of the tumor. My endocrinologist suggests this is the result of a stock effect. Can you elaborate?
Correct. And this is how we call it. We call it stock effect. This is because of the compression of the that the enlarged pituitary generates on the this feedback mechanism, and that is because she may probably have some other underlying hormonal dysfunction, and yes, we call this stock effect. This is not a prolactinoma and usually it's a mild elevation of the prolactin. It doesn't get, depending on the lab, here we use 100, you will never see the levels that you see that are diagnostic of a prolactinoma, so we call those, yes, stock effect.
Okay. What is the best technique for stellar reconstruction?
Stellar?
Mm-hmm.
So stellar.
It says stellar, but yeah, possibly stellar.
It depends on who you speak to. It depends on what you're experienced with. For stellar reconstruction, it depends on what you have to reconstruct. It depends on the size of your defect. I think that if you can get an effective seal between the base of a skull and your intracranial compartment, that's the most effective one. We have all used anywhere from nasal cartilage. We sometimes use some of these custom made or this material called Porex made cellular floor implants. I have become more adept to the use of biologic materials. So if it was my choice, I would use we use a lot of these now that have been popularized nasoseptal flaps, where you can take a piece of the mucosa from the nasal cavity and you rotate it over the floor of the cella, and that usually scars down and creates a nice seal at the cella. Actually, this is a good time to be reconstructing cellas, because in the past we didn't have all these options, and we had to rely more on things like lumbar drains to reduce the pressures through your closure. And my bias is more towards biologic materials. So you can use fascia lata. You can use some aponeurosis. Some people take aponeurosis from the abdomen when they harvest the fat graft. Some people use some free pedicle grafts from the nose, from the turbinates, anything to create a seal.
Great. Okay.
So to answer the question, there's really no best method to reconstruct it.
Okay. What is the cutoff for medical treatment for prolactinoma GH adenoma?
For a co-secreting adenoma you're talking about?
I believe so.
You believe so. Well, if you have a clinically elevated, if you have somebody with a GH adenoma, I would probably treat it if you have elevated growth hormone production.
Okay.
The prolactinoma is not that, I mean, it can be managed medically, but if you do have acromegaly, probably I would consider treatment, depending on the case.
Okay. What are the advantages of the gamma knife approach over the other types of radiation?
They appear to, there's some literature that shows that's more effective in the delivery of the radiation and the tumor control and less side effects.
Okay. Do you advise to do surgery for prolactinomas in childbearing women? We're usually afraid from post-surgical hypopituitarism and infertility.
Yes, it is a concern. We fortunately, knock on wood, don't see many issues with that. It depends on the tumor size. If you have a microadenoma and you're trying to get pregnant, I would just go for pregnancy and have a normal, happy pregnancy. I wouldn't make this the idea of having a ticking time bomb in the head. If you have a macroadenoma that is in contact with the optic nerve, I would consider surgery. We see a lot of, we see a lot of pregnant women who come with macroadenomas, and the response is very, I think it's a very, a lot of it comes down to the endocrinologist and also to the patient and their reactions to having the tumor. If you don't have many symptoms and because sometimes you can have a macroadenoma and you have a safe distance to the optic chiasm. To those patients, I would tell them, just go and carry on with your pregnancy. We can, do more frequently your MRIs just to be sure that you're safe and go on with your pregnancy.
Okay, thank you. In 2005, I had an MRI because of visual disturbances, including 50% reduction in pupil size and reaction. High signals were noted and pit adenoma could not be excluded. Following a follow-up MRT could not detect abnormality. However, now I'm experiencing hormonal problems, low cortisol, hyperinsulinemia, borderline low ACTH, increased renin. Could the HPA axis be the problem and the pituitary problem identified earlier in 2000?
That is a difficult question. To be quite honest, I'm not trying to avoid answering the question, but I think it will require some study of what the sequence of the symptoms has been and what the imaging findings were. Mm-hmm. As I said before, as a rule, I mean, there's a lot of pituitary abnormalities seen that sometimes they're benign cysts or some very small adenomas, and it's hard to, especially if there's no changes, to put all on the adenoma. So I would have to see a little bit better about it.
Okay. Someone asked, is there a way to have a copy of this webinar to discuss options with their specialist? It will be available on our website. It has been recorded. We will have it available on our website so that you can access it if you need it when you go to see one of your physicians, or you can direct your physician to our website to view it as well. I think we are through all the questions. Oh, wait, here's another one. Prolonged use of dopamine agonists can it cause pituitary fibrosis?
We do see, and that's a very good question. Yes, we do see a change in the consistency on the prolactinomas when they have been treated. They become a little bit harder. They don't, usually pituitaries are soft tumors that you can many times take with a section. And we noticed that, yes, treated prolactinoma tend to be harder in consistency. It is true.
Thank you. I had my left adrenal gland in 1991, maybe removed. It doesn't
Probably,
say that, but that's what I'm guessing. In 2011, I was diagnosed with a pituitary tumor, micro, just diagnosed with hypothyroidism. Do you think that the removal of my adrenal is affecting my hormones as well?
No, you can live a perfectly normal life with one normal functioning adrenal.
Okay. What avenue would you next suggest for this patient? 31-year-old female with Cushing's disease, hoping for pregnancy in the future after 2 unsuccessful transsphenoidal surgeries, radiation or adrenalectomy?
Well, first of all, I would like to see the MRI because if this patient has had cavernous sinus sampling, one of the options is to do what we call a hemi-hypophysectomy, where you take part of the pituitary gland, and it's possible that she may be able to carry a good ovulation still with half the pituitary gland if you can get a good surgical result with the surgery with the hemi-hypophysectomy.
Okay. And give it another minute or two. I think that is all the questions. Oh, no, one more. What are the risks of GH replacement therapy after surgical treatment for ACTH tumor, which had recurrence and 2 follow-up surgeries?
What are the risks of GH replacement?
Yes.
Typically in the adult life, I hardly ever see GH being replaced, and then one of the problems is in the childhood more so, where you can create those people to become almost like acromegaly, and they may have some resistance to insulin and diabetes, some of the cardiovascular effects. That's why in the adult life we don't replace the GH.
Okay. 2 years after adenoma removal, now have 13 millimeter cyst. I don't know what the question is, but
this could represent a number of things.
Should it wait for operation until it grows larger or react now?
It depends what this cyst represents. It could be, first of all, be sure there was an adenoma. It may have been what we call a Rathke's cleft cyst that grows in that area, or could maybe just be what we call empty sella, which is cerebrospinal fluid filling the cavity. The other possibility is that if this patient had a recurrence and the tumor has become necrotic and has become what we call a cystic adenoma. A thing of this is, if this is not a functioning tumor and has not grown in size and there is no contact with the optic chiasm, we can continue to watch it. If there's any change in size, then it may be time to act. So if this is a non-functioning tumor, I would neglect the fact that I already had surgery. I would act like any non-functioning tumor. If there's visual compromise, then I would operate.
Okay, thank you. And the person asking the question also says thank you. Okay. Which steroid protocol do you use for your patients pre-operatively?
Pre-operatively at the time of surgery, unless there's any concern from the endocrinologist, we give everybody a dose of hydrocortisone.
Okay, excellent. All right. I think that does it.
Okay.
Thank you very much. Excellent information. Learned quite a bit. This concludes our webinar presentation. Like I said before, it has been recorded and will be available on our website. PNA wishes to thank you for participating in our webinar. There'll be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Dr. Andaluz, thank you so much. We appreciate you being involved and helping all
Thank you
of us
for the
out.
opportunity. Thank you very much for the opportunity, Tammy.
Thank you. You all
Thanks for the time.
have a great day.
Okay, thank you.
Thank you.
You too, bye.
Bye.